All right, good afternoon. Thanks for this opportunity. I'm Dan Feldman. I just finished up my structural fellowship at the Minneapolis Heart Institute, and I'll be presenting a case from this past year. Okay, I don't have any conflicts of interest to disclose. So this case involves a 73-year-old lady who came in with worsening dyspnea. She had a history of a bicuspid aortic valve. She had eventually developed severe AS, required a surgical AVR back in 2011. This was unfortunately complicated by patient prosthesis mismatch and eventually endocarditis and paravalvular leak, so she had to subsequently undergo a redo surgical AVR with an annular enlargement in 2017. She also had atrial fibrillation and CKD. So just jumping straight ahead to her TE, you can see in this initial four-chamber view that it looks like she has actually two abnormal jets going into her left atrium, one that appears to be mitral regurgitation, and then this other jet kind of at the origin of the, or at the insertion of that anterior leaflet. It's unclear where that's coming from. So looking first at her mitral valve, she's got severe MR with a posteriorly directed jet. It appears to be kind of on the medial side of A2P2 on the BICOM view. And then looking at the mechanism of her MR, she appears to have a restricted posterior leaflet. The other jet that we saw in the four-chamber view turned out to be due to an LVOT to the left atrial fistula, which you can see here. And this was confirmed on CT. It measured about 10 by 6 millimeters. So we felt that both lesions needed to be addressed. We wanted to spare her from a third sternotomy, especially since the first two had complications. So we wanted to offer her a percutaneous option. So the plan was to try to close her fistula percutaneously. If that was successful, we'd proceed with MitraClip. If not, she was going to require surgery for both lesions. So if you read the complications course on Wednesday, Paul gave a nice talk with intracardiac rails. And it was kind of our practice that if we're expecting a complex like fistula closure like this, kind of up front to create a rail. So that requires arterial and venous access, and our plan was to cross the fistula from the left atrium into the LVOT. So we got a 12 French dry seal in the right femoral vein, went up, did our transeptal through that, switched out for an Agilis steerable sheath, and then through that we advanced telescoping 5 and 6 French sheaths, catheters, and through those a long angled hydrophilic wire, which we tried to cross with. Unfortunately, we tried for a while to cross from the left atrium, we couldn't, so we had to change our strategy and decide to go from the LVOT side. So we crossed the aortic valve with a JR4 and pretty much just clocked into the defect, almost like engaging an RCA. We were able to engage a defect and advance our wire through the defect and into the left atrium, which is being shown here. The next step in creating a rail is snaring, so that often requires snaring the wire, which can be difficult at times. So in this situation, we were actually going to try a different strategy, and we decided to snare the catheter itself. So we advanced the catheter over the wire into the left atrium, then actually retracted the wire back into the catheter. And since the catheter is nice and directable and steerable, we were able to snare that pretty easily. So we loosely snare the catheter and then send out our wire, and then back our catheter out over the wire, leaving the wire in the snare, which we can cinch down and then externalize our wire, and that creates our arterial venous rail. And Paul had a similar slide in his talk too, but there's several reasons why we do this. One, it provides excellent support. You can really deliver anything you need to, just have to pull on both ends of your rail, and you've got great support. The other is it's a 100% guarantee that you're going to maintain wire position throughout the procedure. So whether you're deploying multiple devices, whether you have to recapture and redeploy, or if you have to switch strategies and come from the other side, you've always got wire position. So next step, we just advance our delivery sheath over the wire, over our rail, and we actually here it's shown going all the way past the aortic valve into the aorta, but we do have to pull that back down into the LVOT before we send out the distal disc of our device, because you don't want to be dragging that back across the aortic valve. So we went up with a 12 millimeter AVP2, which gets sent up just right alongside the rail. Here we're deploying that distal disc. We then pull back into the fistula and deploy the rest of the plug, which is being shown here. So things look pretty good on echo. There's really hardly any residual flow. We do a good tug test, and the device looks like it's nice and stable. So next step is actually to pull your rail. You want to pull that before you release from your cable, just in case you snag your device and embolize it, you'd still be attached to your cable. So remove the rail, and then we can release our plug, and we have a nice stable plug shown here. And on echo, there's really hardly any residual flow through that fistula. So we then turn our attention to the mitral valve, the MR. We had good height on our transeptal, so we exchange out our Agilis for a MitraClip guide catheter. Go up with an NTR clip, which we position over that medial jet that we saw before. Achieve a nice grasp here and get a really nice reduction in our MR. So we're very satisfied with this result until we checked our transmitral gradient, which happened to be 10 at a heart rate of only 55. So the question is, what can you do now? Can you leave it and walk away? Probably not. I think she's not going to tolerate that very well, and that's really not an option. There's really no option for reposition. I think you're in the spots you need to be, and there's really nothing else you're going to do to decrease your gradient by regrasping. Is it time to admit defeat and go to surgery? Hopefully not. That would be a shame if we had to do that. So is there any other option? Turns out there's one other thing we thought that we could do. It's not, I don't think, widely publicized, not very commonly practiced, but you can open up your clip arm to 30 degrees and still release your clip at open to 30 degrees. So that's what we're doing here. You can see it on the loop. It's subtle, but you can see how the clip arms kind of open up to 30 degrees. So when we do that, our gradient actually dropped to 5, so we were able to cut it in half. And we really didn't lose anything as far as reduction in MR. We still had a really nice result on our clip. So we were satisfied with these results. We were confident in our grasp, and we released the clip. So that's shown here. It's stable in 2 projections. It's a little unnerving to see the clip arms open wider than you normally see when you deploy a clip, but it was actually very stable. We had a great result on echo. Just a few more shots showing both devices. We've eliminated those abnormal jets that we saw in that initial 4 chamber. Just a 3D view showing both devices in position. I saw her at 1-month follow-up. She was doing great. She felt a lot better. Her shortness of breath really improved. On echo, there was no residual flow across the fistula. She only had mild residual MR. Her transmitral gradient crept up to about 7, which isn't entirely unexpected. It's suboptimal, but probably acceptable for her. So just in conclusion, you can approach intracardiac shunts from either side, both with lesion crossing and device deployment. You should probably have an initial strategy, but if you have to switch sides, that's always a possibility. Intracardiac rails can be used to facilitate device delivery, and if you're going to use a rail, you're going to have to be able to snare it. So this is just an example where you can actually snare the catheter instead of the rail. And lastly, you can open a MitraClip to 30 degrees to try to minimize your transmitral gradient as long as you've got a good grasp and you're confident in your grasp. So thank you.
That's a great case. I have a few questions for you. So what was the reason for closing the fistula? I mean, we don't know. It could have been there since the last surgical valve. And sometimes these people tolerate the fistula okay.
Yeah, I mean, I guess, from the best of our knowledge, this was new at this presentation, but I guess you could have tried just doing the MitraClip and seeing how she did, and then do the fistula. I think we were just trying to do both at one time to kind of spare her from multiple procedures.
Sure. And what was your transseptal strategy for closure of the fistula? Like, where were you trying to do the? Oh,
we were planning on doing the MitraClip as well. So we wanted
the same in
exactly.
superior, posterior.
Yeah.
Okay. Yeah. And how did you size the AVP2?
Generally kind of just start with a 12 millimeter, and we had a measurement from our CT that was I think 6 millimeters in diameter. We often just start with our 12 unless we know it's a lot bigger or a lot smaller, and see how it fits.
Okay. And what kind of clip was it? Was it XTR or?
It was an NTR.
An NTR, okay.
Yeah.